All right, we ready to go, everybody? Hi, everybody at home on the live stream. And we're going to go ahead and get started with our next session. I have the pleasure and honor of introducing Dr. Pierluigi Porcu, who is a hematologist oncologist at Thomas Jefferson University, and I should probably read the whole bio here because I don't know it off the top of my head, which is really horrible. Professor of Medical Oncology and Director of the Division of Hematologic Malignancies and Hematopoietic Stem Cell Transplantation in the Department of Medical Oncology at Thomas Jefferson. But Dr. Porcu has been a friend and clinician with us for a long, long period of time, former board member, chair of our Research Advisory Council, and it's just an honor and a delight to have him today to talk about the landscape of systemic therapies, and then we'll have a little bit of time after for some Q&A, so I'm going to turn it over to Dr. Porcu so I don't take any more time, because what he has to say is going to be great.
Thank you, Susan. Okay, this is working, that's great. Put it here. Lovely basket, by the way. I really enjoy the art talk. I'm going to try to see. Okay, great. So first, I want to say that there are two simultaneous sessions going on, and most of you probably already know, but just in case, each session is going to be recorded, and therefore, if you're missing this section or the other section later, you will have the opportunity to see it online. So it's a great pleasure, Susan. Thank you for inviting me here. As Susan mentioned, I've been with the foundation for, I guess, 20 years, perhaps even more. And I've seen the foundation evolve over time from a very dedicated small organization now to a large organization with international footprint, thanks to the hard work that Susan did, and then the terrific staff that Susan really kind of recruited over time. So the foundation is just a phenomenal organization. The goal of my talk today is primarily to give you an idea of the landscape of systemic therapies. So I'm not going to spend a lot of time talking about how you make a diagnosis of CTCL mycosis fungoides, Sézary syndrome, but I'm happy to answer any question related to things and matters that are not directly discussed in my presentation. These are my disclosures. So I always start with reminding people that mycosis fungoides and Sézary syndrome really are malignancies, cancers of the hematopoietic system or immune system. And what this slide shows is the fact that all the hematopoietic cells, so the blood cells, really originate from tissue that is called bone marrow. The bone marrow is, as the name says, in the bones, and there's a lot of it during our younger age, and then it becomes a little more restricted to certain bones. But still into old age, that's where all the blood cells are produced. The blood cells, you can see them here on the right, are essentially divided in lymphoid cells and myeloid cells and then red cells. And the little square, in red square shown there, actually identifies all the different type of lymphocytes. Those are the cells from which lymphomas eventually develop. And cutaneous T-cell lymphoma is a type of malignancy that derives from T cells. So this is where the source of the CTCL is. Why it develops primarily in the skin, at this point is still not entirely clear. But what we know is that normal T cells, they travel a lot throughout the body as part of their normal function. They go to all the organs, and they do that because it's very important for these cells to affect what we call immune surveillance. And they do that by trafficking in and out of organs, including the skin. The skin is one of the organs that has the greatest concentration of T cells and number of T cells in the body. And that is part of the reason is that the skin, as you can understand, is the primary organ one of the primary organs of our interactions with the environment. So if we look at this, it's understandable that when you have a T-cell lymphoma, so one of these cells becomes malignant, then those cells will retain a certain number of functional features that were part of their normal initial function. And therefore, these lymphomas are really never completely localized to one organ or one part of the body. They travel everywhere. And that includes cutaneous T-cell lymphomas, of which mycosis fungoides and Sézary syndrome is one type. So, as you know, we doctors always like to list things, classify them in different ways, and that sort of helps us just keeping things in a certain order, and then also in particular to make sure that when one doctor talks about one type of disease, every other doctor knows exactly what they're talking about, or patients or policymakers. So it's important to have names so that we all know what we're talking about. And this is the classification. I'm not going to go through it, but essentially what you see is that mycosis fungoides and Sézary syndrome are a very important component of these cutaneous lymphomas, but it's not just the only type. There are a lot of other rare types. Clinically speaking, you probably are already familiar with the different manifestations and clinical presentations of mycosis fungoides and Sézary syndrome, and with the very fundamental initial skin-based staging, which is very old at this point, and that divides the type of lesions that you see in the skin called T from T1 to T4, depending on the type of lesion and the extent of skin that is involved. This is important because we use the skin stage T as one of the drivers of the overall clinical staging for mycosis fungoides and Sézary syndrome. So because of that, how do we actually achieve the goal of clinically approaching the patient and staging? So in the clinic, this is meant to provide an idea of what we do in the multidisciplinary clinic, CTCL at Jefferson. Doesn't necessarily mean that this is what everybody else does or what everybody else should do, but I know this gives kind of a snapshot of what we do on a regular basis. And so, obviously, physical examination is an important part, essential part of the initial approach. There are some imaging or radiological tests, whether it's PET scan or CT scan or ultrasound sometimes. Biopsies are very important, obviously, so lymph node biopsy. Every time that there is kind of a palpable lymph node that is sizable enough to really kind of catch the attention, the lymph node should be biopsied, whether to do an excisional biopsy or a needle biopsy. The only thing that we really discourage are the so-called skin and needle biopsies, where you don't get any architecture, and it's impossible to really figure out where those cells are coming from. But other biopsies are fine. Then there is the immunophenotyping, which is a very long word, with a lot of CDs. All these are surface markers, standardized surface markers that can be measured either by immunohistochemistry or by flow cytometry. And depending on which one of those markers are expressed on the cells, then you can sort of use that combination to classify the lymphoma. The other thing that can be done is to figure out whether the cells are expressing certain markers that are really important. For example, CD30. And then there's some additional tests like molecular genetics, the T-cell receptor rearrangement. Other biopsies, like a bone marrow biopsy, that may not be necessary or relevant in fact, in most patients, I would say, except when there is a substantial involvement of the lymph nodes or the counts are abnormal, or in Sézary syndrome, then I think that the bone marrow biopsy is important. And so there are additional tests that can be done depending on on the team, on the center, and they may not be available in every place. But additional markers for the immunophenotyping, for example, CCR4, which is the target of mogamulizumab, EBV, Ebering cytohybridization, CD30 by flow cytometry. You can go through the list here. All of these things are helpful, but they may not be done or they may not be available in some of the offices or centers where, for example, everybody is being treated, and that may, doesn't necessarily mean that they're missing something. So full body photography, that's something that we do in the multi-D. We find it very helpful to kind of monitor the evolution of lesions over time. It's impossible to remember, how exactly the skin looked like, 3 months before. Through all those tests, then with the results of all those tests, then we can actually do two things. One is stage mycosis fungoides and Sézary syndrome according to the different size. It's called TNMB, which stands for tumor, lymph node, metastasis will be visceral organs, and blood. And I'm not going to go through all the details of this, but it's important when you have all these results back that you can actually pick one of these specific subclassifications and then move on to this, which is the so-called composite clinical staging, where you put it all together, essentially. You look at the T, the B, the N, and the M, and you come up with this sort of list of clinical stages. And we use this to kind of, for the clinical approach, by dividing patients in so-called early stage, which includes stage 1A and stage 1B, although you can add stage 2A there. I call it the Phoenix because I don't think it exists, actually, stage 2A, but nonetheless. And then everything from stage 2B to stage 4, A and B, that's advanced stage. So in terms of the general introduction, this is how we approach the patients. This is, and this is all done at the beginning. So in other words, the stage is defined when the patient comes in, or at least is diagnosed with MF the first time. So then once we have the diagnosis and the stage, how do we use that information? We use it to sketch a little bit what we expect the natural history of that patient to be moving forward. And there where we have to be a little careful because, as all of you know, making prediction is always difficult, especially about the future, like they used to say. So we're really not good at making strong predictions for the future. We're good at sketching general outlines of probabilities of things to happen. And I think this is really, really important because when we are seeing a patient and when the patient is in the office, it's like one patient at a time. We're not talking about, we're not applying statistics to individual patients. We use the statistics to provide some general idea so people can navigate the system. But it never is something that is for sure is going to apply to one individual patient. That's very important. So how do we measure outcomes and prognosis? And, we do it through these curves, okay, and these graphs and plots, where on the x-axis, for the most part, there is time. This time can be months, years, decades, in this case it's years. And then on the y-axis, we measure different things. So on the most left-hand side, what is being measured there is how many patients or what fraction of patient is alive. That's called survival. You start at time 0 and everybody's alive, of those that you are looking at, and then over time, how many patients are still alive. The one in the center is risk of progression or progression-free survival. So in that case, it's different. It's not just alive, but is alive with no evidence of progression or no evidence of disease. And so that's a slightly different endpoint. But on the y-axis, you always have the endpoint. So you follow this over time. You see how many patients starting at time 0, they move on over time, over years, and actually they hit that particular endpoint that you're interested in. And based on this, we have an idea of what the overall population that we are looking at does. So the first two curves are coming from work that was done at Stanford by Dr. Jan Kim, many years ago. And essentially, they give you an idea of survival chances based on different stages over time. And the one in the middle is from the same data set looking at odds of progression, again, based on different skin stages. Again, these are just data to give us some idea what the outcome of the patients overall is going to be. The one on the right is a much more recent one, which is an international collaboration called CLIC, which is run by Dr. Scarisbrick in the UK, Julia in collaboration with Jan Kim at Stanford. And this much more recent sort of effort with a very large population, I'd say almost 1,300 patients, looking at prognostic markers for survival in patients with advanced stage mycosis fungoides. And you can see that there are at least two big group patients with a better or worse prognosis, perhaps even three. And the statistics is significant for the third. So there are three different groups that two of them cluster a little together based on the stage shown here. If I can, yeah, there we go. Stage, the elevation of the LDH, which is a blood test that everybody should always get, particularly with advanced stage, age, 60 or older, and then large cell transformation. So these factors then, when we see patients in the clinic, if they have advanced stage, we always look at these factors. We want to know, these, because based on this, we can figure out whether somebody has a slightly higher risk advanced stage MF or lower risk advanced stage MF. It doesn't change necessarily, our prediction what happens with that individual patient, but it's important to have some general ideas. One thing that is emerging as really important now is the involvement of the peripheral blood with Sézary cells. That doesn't necessarily mean that you have Sézary syndrome, because Sézary syndrome really requires somebody to have a B2 blood stage. If you don't have B2 blood stage, then you have circulating cells, but not to the level of Sézary syndrome. And so we have this blood stage classification, B0, B1, and B2, which you can only really figure out whether you have B0, B1, or B2 by having cytometry done, unless you have so many cells in the blood that you can see them under the microscope, but most of the times that's not the case. So if you look at the presence of B2 is really emerging as a very important prognostic factor in advanced stage MF. So very important to get flow cytometry. This is a slide which is not necessarily applied specifically to mycosis fungoides, but it applied to any indolent chronic cancer. But it's a good fit for the natural history of mycosis fungoides. And I like to use it because it gives a good idea of, over time, what the things that we're looking at in patient care. And that is the same for mycosis fungoides. So patients get diagnosed at the beginning. They may or may not initiate treatment right away, but at some point they start treatment. Over time, the time here is in the arrow moving to the right. At some point, there will be a response or lack of response in this case. Then you're going to have to reassess the situation. And then you're going to have, of your planned course of therapy, and you figure out what quality of response people have. It has been a complete response, has been a partial response, and so on. And then depending on the type of cancer, in this case, it doesn't fit exactly CTCL, but in some cancers, you actually stop treatment altogether. In CTCL, very often, we continue with maintenance for an extended period of time. And then you follow up the patient, and then at some point there is relapse, progression, and then you you reassess, and you go back and you restart the loop here. Throughout all time, the important things to look at are what we call these endpoints, clinical trial endpoints. Again, survival, progression-free survival, event-free survival, time to the next treatment. All these are more sort of research endpoints, but they can be applied also to understand overall patient care. Of course, another big important endpoint here is quality of life, which we believe that it should be applied to just about any time point in the natural course of patients' treatment and disease. And so for CTCL, particularly mycosis fungoides and Sézary syndrome, the natural history and the type of treatment continuously loops from one to the next and so on. And of course, you essentially add specific treatment on this curve. So a couple of things about the natural history of mycosis fungoides that I like to point out. One, on the left, the kind of the triangle going down gives these are very generic sort of conceptual ideas about what happens to the immune system. We know that in terms of the immune system, from the earlier stages of mycosis fungoides to the more advanced stages, the immune system clearly is more and more impaired. It's not just the treatment, but also the specifics of the disease that lead to immune system impairment. Earlier in the disease, we have this, what I call a dynamic but stable equilibrium, between the cancer cells that are kind of acting up in the skin, the immune system that is controlling them, and that can go on for decades in some patients. But then at some point, you have kind of still a dynamic but unstable, I call it, equilibrium, where the cancer cells are taking more and more over in the skin, and there's less and less ability of the body, of the immune system, to control it. And then eventually, the last one is you have a really kind of aggressive disease. This is where the CTCL can actually behave just like any other aggressive lymphoma. There's a lot of mutations, oncogenes are activated, the immune system is significantly depressed, and that's why throughout all this natural history, you see that depending on the stage, the survival changes. So one of the goals is that somebody is presenting with a stage like this, which it doesn't happen very often. My experience, and I think everybody's experience, is that the vast majority of the patients, who present, so to speak, with advanced stage, they have a history of earlier stages before. And so what we want to do is trying to prevent this transition from this point to this point. How often that transition occurs, There's not a whole lot of great data, but this is one of the best data sets that is available. This is from our friends Pietro Quaglino and the Italian group in Torino, where they looked at patients, 1,200 patients that had different stages to begin with, and then over time, over 30 years, they saw how many of them actually moved, to a more advanced stage, and you can see is not a trivial amount because even with stage 1A, which is the earlier stage, about a small percentage of patients move on to stage 1B, stage 2B, and even stage 4. And if you start with stage 1B, the percentage is significantly higher. So this may never happen in one person's lifetime, but if you have a very long sort of stretch of time, as in patients who get diagnosed in a young age, the overall risk, is not trivial, and therefore we need to be really careful in how we treat these patients, how we monitor them, and how we try to retain as much as possible a functional immune system for the long run. So these are the goals of therapy overall. This is not my slide. I took it from one of the talks. from the foundation before, from I can't remember who now, but I like it. I subscribe to this idea wholeheartedly. And essentially, when we add systemic therapy, so as opposed to skin-directed therapy, now these are the goals. First of all, in early stage, patients who have gone through multiple rounds of skin-directed therapy and they still have, active disease and so on, then at some point you're going to have to start systemic therapy to try to prevent, those lesions to become more advanced or more disseminated and change into tumors. In advanced stage disease, obviously, the need for systemic therapy is clear, and sometimes what we have to do is, we have to combine more than one systemic therapy, and we have to combine it always with skin-directed therapy. So doing skin-directed therapy remains important and vital throughout the natural history of the disease. And then, most importantly, we want to make sure that we don't, make the treatment worse than the disease, which can be very easily done. And I still see this every day. Patients with, early stage or, advanced stage, but not quite refractory, that get way too intense therapy for no good reason. These are the drugs at the moment that are either FDA approved or are in common clinical use for a patient with advanced stage refractory relapse CTCL. They're listed there. Romidepsin, Denileukin diftitox, which is an old drug now. There's a new version of this drug that is approved. Targretin, bexarotene, vorinostat, and brentuximab vedotin and mogamulizumab. Through some of these treatments in a little more detail and see. So first I want to mention that over the past 10 to 15 years, there has been some major progress in clinical research in CTCL, which has been difficult because the disease is rare. But the large clinical trials were eventually conducted, leading to the approval of key drugs that we use in the clinic every day. So the Alcanza trial was the first one, was a randomized phase 3. The new drug was brentuximab vedotin. Many of you probably are familiar with this drug, and versus investigator choice. The target of the drug is CD30, and the clinical trial was completed, and the drug was approved. So this drug is on the market now because of this trial. Maverick is next, also a randomized phase 3 trial. The drug is mogamulizumab, which many of you probably know. The comparator was vorinostat. The target is CCR4, and the trial was also completed and the drug approved. And then the third trial is Telomac. It's not a phase 3. It's a large multi-cohort phase 2. The drug is lacutamab, which it targets KIR3DL2. The trial has been completed to accrual, is fairly advanced even in the follow-up, and currently the drug is under review at the FDA to figure out what the next steps leading to a full approval actually to an accelerated approval of the drug is. So starting with brentuximab. Very briefly, brentuximab targets a marker on the surface of the cell called CD30, which is expressed on a very small subset of normal T cell and NK cells, but it's expressed fairly strongly on a variety of different types of T cell lymphomas. Again, it was a randomized trial, and this is the outcome, meaning that if you look at the progression-free survival here was significantly better and improved compared to the control. Control was either bexarotene or methotrexate. So with this clearly was a positive study, and this included not just mycosis fungoides, but also anaplastic large cell lymphoma, and this led to the approval of brentuximab, which we use all the time now in CTCL. Maverick was a trial that looked at an antibody, not a naked antibody, not immunoconjugate, against CCR4. And this was the design of the trial with patients receiving either vorinostat or mogamulizumab with this schedule here. And again, the study was very strongly positive, multiple endpoints, and this drug was also approved. One of the interesting things about Moga is that with more and more use, it become very clear that Moga is associated with rash. And it is very difficult to tell whether the rash in a patient with CTCL is really due to a drug reaction or is due to progression of the CTCL. Sometimes you can get a little bit of a sense with experience, but very often it's just impossible to tell the difference. As you can see, the rash looks many different ways in patients, and the only way you can tell the difference is by doing a skin biopsy. So we recommend anybody with a skin rash on Moga to do a skin biopsy to tell the difference. There are also some very special molecular genetic assays that many centers do. We do it at Jefferson. That is crystal clear, can tell you for sure whether it's a Moga-associated rash or not, but that is not available in most places. By the way, if it is a Moga-associated rash versus progression of disease, obviously what you want to do is you want to continue with the Moga treatment, not necessarily stop it. So you may have to sort of hold it for a few weeks. People often go on prednisone, but in many cases you can actually resume mogamulizumab for continuation treatment. It's very uncommon that we have to stop because the rash gets worse again or recurs and so on. One of the interesting things about the rash that is coming up is that it seems to be predictive of actually a better response. And the data are still relatively limited, but there's a large retrospective study with almost 160 patients there, and then also individual experience different centers that very strongly suggest that the rash actually predicts a better outcome. So it may not be that bad if you get a skin rash from Moga. The last drug is lacutamab, which is an antibody, also a naked antibody that targets KIR3DL2 and works through, it attacks both, tumor cells expressing KIR3DL2. KIR3DL2 is expressed in about a little more than half of the patients with mycosis fungoides, and is expressed on 95% plus of the patients with Sézary syndrome. A very strong expression, and the antibody binds to KIR3DL2, and then you have, both NK cells and macrophages that actually are connecting to the antibody and killing the lymphoma cells. The trial that is called TELLOMAK, as I mentioned, is a phase 2 with initially 3 cohorts. One was Sézary and 2 cohorts of MF, and then there was another cohort that was added later on, just looking at different ways of measuring KIR3DL2. And it had, all these different endpoints right here, particularly progression-free survival was the primary endpoint for clinical efficacy. There was no comparison here. This is a phase 2, everybody was getting lacutamab. And these are the results for the Sézary syndrome, which is the one that really has the most mature data, and for which the data look so strong that we all hope that this is going to be leading soon to the approval of this drug by the FDA and the European agency. And so kind of response overall here, 37, almost 40% in terms of the global response, and then responses across all the different compartments, particularly in blood. These responses are very fast. The first responses are seen in about a month time. The safety of this drug, which is not shown here, is very good. In fact, of all the 3 drugs, my experience is that it's the one that has the safest toxicity profile. There's no skin rash or autoimmune complications so far on the follow-up. So one very important component of all three of these trials is that they did measure quality of life endpoints. And I think that this has now become a fundamental sort of type of analysis for any new drug in CTCL. I want to point out that the very first quality of life study to be done in CTCL was done thanks to the Cutaneous Lymphoma Foundation sponsoring one of the investigators who really had Marie France, who was a dermatologist in Boston, who had this passion about quality of life and could never find anybody to sort of sponsor her research in quality of life. The foundation stepped up and provided support. So congratulations, Susan. That was kind of a game changer. So now everybody's measuring quality of life. And I don't have the data for the Alcanza trial, but I have data for Mavorec and the Telomac. This is just a summary, specifically in Sézary syndrome. The previous speaker was talking about itch, and we know that itch is just kind of one of those endpoints that, if you make the skin look perfect, but the patient is still itching like hell, what good is that going to do, right? So I think it's very important to look at itching. This is the endpoint here is something called Skindex 29, which is a more composite, multi-domain quality of life endpoint. But all the studies included itch, which generally is measured through something called visual analog scale. And what I want to point out here, if you look at this on the left of this bar right here, everything on the left looks that favors mogamulizumab versus vorinostat. And you can see it's very strong, particularly in patients with Sézary syndrome. It's strong also for all patients, but Sézary syndrome really came out very strongly. And there was a quality of life analysis also done for Telomac, which we presented at ASH actually just last year in December, and included both and Skindex 29. What I'm showing here is primarily the Skindex 29, but it really also showed a very significant improvement in itch. The way to read this fairly complicated color-coded graph is that you start from the bottom. This is time right here, from the bottom all the way to, over time, how many weeks have gone by. And then the colors simply represent, yellow and orange represent not good quality of life, and green represents better quality of life. And so what you want to see is, starting with the treatment here, going up over time, you want to see more and more and more green and less orange and less yellow. And this is true both across all symptoms, the functional, so how functional people are in their daily activities, and also psychological and emotional well-being. And so in all three, so in general, but also individual components, you see that, the orange pretty much goes away. And that was for Sézary syndrome, this is for MF, and essentially you see the same thing. All right, a few more slides about some specifics of treatment. One is, this is the laundry list of possible treatments for patients with advanced MF and Sézary that is taken out of the NCCN guidelines, which is a kind of a tool of clinical practice guidelines and recommendation that every oncologist uses for treatment of all different cancers, and there is one specifically for MF and cutaneous lymphomas. And what the NCCN does not necessarily recommend one versus the other for good reasons. It just provides the list. The problem is that when you have all these different options, how do you pick one of them? And that is left really to the choice of the investigator. If there are very, very strong data, the only thing that the NCCN does is it provides a numerical code of what the strength of the evidence is. And because it's a kind of an expert-based consensus, if everybody at the table thinks that this drug is great, then that's going to be a category, consensus category A, or 1. And if there is no consensus, then that number goes down. So that's the only kind of guidance that the NCCN provides. It just allows people to select whatever treatment they feel that they want to select, because most payers and most insurance companies, as long as the treatment is listed in the NCCN, they will cover it. So it gives you essentially coverage for the treatment that the doctor wants to select. So then, how do we use, all those different options for patients? And that comes down to, there are certain things that every large multidisciplinary center does, and then something that are more specific to individual centers. And so I'm just providing here a snapshot of what our approach at Jefferson is. And so I'm going to just walk you through briefly here through this flow chart. First, we start with the early stage mycosis fungoides. And that means that early stage means either you have limited skin involvement, this is what 1A is, or you have extensive skin involvement, which is 1B. If you have limited stage involvement, topical therapy with steroids, Valclor, retinoids is a very good treatment option here. If you have extensive skin involvement, so much more than 10%, then doing this or just this may not be feasible, and it's very hard to kind of cover the whole body with lotions and creams. That's when we tend to go to phototherapy, very often adding or maintaining topical therapy as well. Rarely we do skin-directed electron beam radiation therapy for patients with early stage MF. Some of the things that we do, we always look for the evidence of large cell transformation. So any concern, we do skin biopsies. We look for expression of CD30 even in early stage, just to have an idea of whether CD30 becomes an option. And as I mentioned, we always look for blood involvement. We want to know whether patients have B1 stage blood or not. And then when people have progressive disease, so new lesions, new skin involvement, then we continue with more topical therapy, phototherapy if it was not done, and then total skin. This is where we often resort to total skin electron beam. Or after total skin electron beam, very often we do maintenance therapy with one of these drugs, either retinoids, interferon, or mogamulizumab. Most patients with early stage MF do very well, and they can go on with this sort of type of approach for decades without needing any other treatment. For patients who have the second category is patients with advanced stage, really mycosis fungoides, so skin-based advanced stage, so 2B. For those patients, we look very carefully for the presence of large cell transformation or CD30 expression. Those two things always often go together. And so if there is large cell transformation and there is CD30 expression, our first systemic therapy is brentuximab. So we go directly to brentuximab vedotin. If the patient, on the other hand, does not have CD30 expression or minimal CD30 expression or large cell transformation, and they have B1 disease, then our first systemic therapy option is mogamulizumab. So that's how we decide whether we start with brentuximab or we start with Moga. And then, of course, there's nuances and subtleties, in patient-based, but broadly speaking, this is the approach. The second line systemic therapy in these patients then becomes romidepsin. So when patients progress with brentuximab and Moga, and by the way, very often patients can be retreated multiple times with both brentuximab and Moga, so it doesn't mean that immediately you have to switch. But once it becomes clear that it's not working anymore, then romidepsin becomes our next choice. And then after romidepsin, same principle. Then that's when we go to retinoids, interferon, or other therapy, single agent chemotherapy, for example, and so on. Every time there's an option to have a clinical trial, we like to put patients on clinical trial. So that's for the advanced stage, tumor stage MF. This is how our algorithm goes. For patients with either new onset or MF evolved Sézary syndrome, so these are patients who have extensive erythroderma and they have involvement of the blood, so-called stage B2. We divide those patients in two categories. One is, we call it relatively low tumor burden. These are made-up categories. These are not standardized consensus categories. This is what we use at Jefferson. Other people may have other cutoffs here. We call it low tumor burden if you have 1,000 to 2,000 cells per microliter. There is no pathologically involved lymph nodes, and CD30 is either negative or very little expression of it. You may have a palpable lymph node, but here I mean a biopsy that shows no evidence of lymphoma in the lymph node. Then that's what we use, the lower intensity kind of systemic therapy for Sézary, which is bexarotene, extracorporeal photopheresis, ECP, and interferon. This is the type where we do that. For patients who have high tumor burden, which means more than 2,000 cells, if the lymph node biopsy may actually be positive, so you do, people have a palpable lymph node, you do a biopsy and you find the Sézary cells in the lymph node, and they are CD30 positive or there's large cell transformation. We actually treat those patients as we treat CD30 positive peripheral T-cell lymphoma. So a much more aggressive approach. That is based on the fact that in our experience, if we treat these patients with ECP, interferon, bexarotene, the vast majority of them doesn't respond or doesn't respond well enough, and they progress. Sometimes they crash because these treatments take weeks and months before they really start working. And this, on the other hand, works much, much faster. So the issue is that, as you all know, even with brentuximab, chemotherapy by itself doesn't really produce very long responses. And so we have to be mindful of the fact that after this, you really have to continue with additional therapy. And our approach, again, this is our approach. It doesn't have to be the same in every place. But we like to use Moga as a maintenance after the BVCHP. And then we follow Moga with romidepsin, because they have two different mechanisms of action. Moga is very strongly immunomodulatory, and romidepsin is a good effective drug for systemic therapy, including nodal disease. So we like to use them both. And of course, for patients progressing on this therapy, eventually we take them to an allogeneic stem cell transplant. Now, the good news for everyone is that there are an incredible number of new drugs being tested in mycosis fungoides and Sézary syndrome. I'm not showing any details about any of these drugs because most of it is really early on. The important thing for you to know is that many of these agents are quite promising. And so I'm sure that over the next 5-6 years or so, they will become, we will learn much more about how active they are and how safe they are. And some of them, not all, some of them will kind of emerge eventually as winners moving forward. And this is our team at Jefferson. It's a phenomenal translational team. We have the multi-D, we have people in the lab, visiting students from Europe, a bunch of students. So thank you very much. I'm happy to answer any questions whenever Susan and Autumn think is the right time.
Thank you, Dr. Porcu. I think we are running up against our lunch hour, sadly. So I think we'll just have to take questions for our open Q&A tomorrow, unless someone has a super burning question that you want to add. We'll do one question. Deb's going to bring you a microphone. Okay. There you go.
Hi, thank you for the...
sorry to interrupt, by the way.
Sorry.
I think that just for everybody else, I mean, since I'm sticking around, so if you have questions after this, I'm happy to answer any questions. So go ahead.
Hi, thank you for the presentation. That was great. I wanted to inquire in terms of like systemic treatments. Is it common? I'm only going to speak on my specific experience. Is it common for romidepsin to be the first line, and then is it possible to kind of switch back and forth with Moga if romidepsin is the first line of treatment?
Yeah,
Or?
it is possible. There's nothing really right now that prevents one of those two drugs to be sequenced in a different way. We used to go to romidepsin as a first line often before Moga was approved. And romidepsin works really well both for nodal disease and for lymph nodal disease as well. But with blood involvement, generally Moga is our preferred. And also we feel Moga it's a little safer than romidepsin, has a little fewer side effects. But if somebody has, for example, lymphnodal involvement, then romidepsin, in my opinion, has better established efficacy in lymphnodal disease as opposed to Moga, where the data are not, great for that. Yeah, thanks. Okay, thank you.
Thank you, Dr. Porcu. And
Okay.
as he said, he'll be around, and we really appreciate your time and energy. So, yes, thanks so much. I think we're up for lunch, yes?
Okay, thank you, Dr. Porcu, for responding to these. So the first question is, how often can triamcinolone injection be used for MF itching?
So triamcinolone is a topical steroid, and so usually it's not injected; is just applied to the skin. It can be in ointment form or a cream form, and triamcinolone itself is usually applied that way. It can also be injected less frequently, it can be injected as many times as necessary, depending on the size of the lesions.
Thank you. How do patients react to full body radiation? What are the desired outcomes? And do you have any hints for preparing for treatment?
So, total skin electron beam radiation is typically leads to very good responses, but relatively not very long. So on average, 12 to 18 months, responses after radiation. After that, very often, new lesions start to appear, and therefore the duration is not very, very long. So what we often do is we add maintenance therapy in the form of either skin-directed. So sometimes people do Valchlor for maintenance after radiation if the skin involvement is not very extensive, or systemic therapy, and you can do it with a variety of, you can do it with Moga, you can do it with bexarotene, sometimes even methotrexate. So there are a number of different systemic therapies that can be used, and those help maintaining kind of a longer duration of remission after total skin.
Thank you. While a potential side effect of brentuximab treatments is peripheral neuropathy, can it also lead to autonomic neuropathy?
Oh, wow, that's a great question. The answer is yes, but it's a very, very uncommon event. A lot of different drugs that cause sensory neuropathy, which is the primary side effect type of neuropathy, can also cause autonomic neuropathy. So that happens with chemotherapy and other drugs. It can happen with brentuximab as well, although I've seen it only in a handful of cases over many, many, many years, so it's not very common.
Speaking of not being very common, how many people have only who have CTCL-MF may also have multiple sclerosis or hemochromatosis, or is she alone in this? Her neurologist says she's a snowflake.
Yeah, wow. I'm not sure I can make any strong comments about that. You know, multiple sclerosis is actually not that a rare disease. And so I don't see why not. People could have, you know, CTCL and multiple sclerosis. I'm not aware of any particular link between those two things, so not impossible. The other diseases are also very rare, so I think you know, would be very uncommon to see that. I'm not aware of any linkages between any of those diseases and CTCL. Sorry about, I cannot get a better answer to that.
We just want to thank you, Dr. Porcu, for having to end our Q&A with that question. Any Q&As that weren't answered, we'll get to in tomorrow's Q&A session. Thank you so much for your time and responding to these extra questions from our online audience.
Thank you, Deb. It was great to be here.